Tonight's presentation is looking for camouflaging breast masses with Louise Worley. Louise works as Tutor Sonographer for MIA IMED, Northeastern Region. She has presented at many ASM and ASA local branch and national meetings as an invited speaker for obstetrics, breast, gynecology, abdominal and MSK ultrasound. She was awarded ASA Trainer of the Year in 2013 and ASA Victorian Sonographer of the Year in 2017. She has been on the ASA SIG Breast Ultrasound Committee and presented webinars and workshops on breast ultrasound for both Toshiba and the ASA. Louise published an article on breast ultrasound in the ASA journal, Sound Effects, and she was recently awarded an Associate Fellowship of the ASA for her contributions to ultrasound. And now I will hand over to Louise. Welcome, Louise.
Thank you very much, Claire. Breast ultrasound, looking for camouflaging breast lesions. So here we can all easily recognise if there's a mass. And we can have a pretty good idea of what they are. You can see that, we've got a spiculated lesion with branching edges and a few little microcalcs. This one's got nice sharp margins, just like a fibroadenoma. This one's a cancer and it's got a strong desmoplastic reaction. And this one's got lots of angular margins and strong vascular stalk marching through it. And of course, this is a cancer. And then we've got this simple cyst. And you may even recognise this hamartoma. There's often been these ultrasound criteria for malignant findings, and I first heard of these in 2008, and it was fantastic. Ultrasound was really advancing, and it's still changing. We used to describe things as having spiculation for malignancies, or angular margins, or microlobulation, and we described masses as being circumscribed, and most masses we learnt were taller than wide, and that's because they actually start in the TDLU and then migrate down the duct, and that makes them longer than tall. However, we do find if they're in the terminal ductal lobule, they'll be wider than tall, or if they've got extended outside the duct. We thought that cancers were hypoechoic, but as you'll see, most of the camouflaging lesions are hyperechoic, isoechoic, mixed, or even anechoic. We're getting much better at looking at calcifications, just like they do on mammograms. We're looking at the type of calcifications, and particularly when we're looking for recurrence or any non-defined, non-mass-like invasive lesions. We thought cancer shadowed, but you'll find that the more aggressive cancers enhance. And then we look for this branching pattern and duct extension, and of course the desmoplastic reaction, which I'll talk about later. But my biggest thing is these. Looking at the anatomy, we're looking for disruption of the tissue planes through the premammary fascia or through the ducts. And this is where you'll pick out the tiny tumours which you'll see. And often cancers are retractive. They actually bite through these layers, and then we may be able to test with the probe the surrounding tissue effects. Because cancers, even if you haven't got elastography, are non-elastic and firm. They're often non-mobile, and then of course we use low flow settings to look at the vascularity. The desmoplastic reaction is the response by the body to wall off the tumour with fibrosis and elastosis. And this happens just like when you have an implant put into your breast, your body puts out a capsule, a fibrous capsule. And this is because the cancers are developing more slowly, so the body puts out this response. Speculation. Speculated masses are a form of desmoplastic reaction as well, and they're usually slow-growing tumours, and they tend to have more shadowing and are not as vascular as these aggressive cancers. And you could be forgiven for thinking that this initially was a fibroadenoma. These masses grow too fast for desmoplasia to develop, and they tend to be grade 3 tumours and more circumscribed masses. They might have posterior enhancement, and they might be more vascular. The lesion on the lower area was in a breast full of cysts, So you could easily run over it. But of course you can see that it's got a solid component, and this is a highly aggressive cancer that is necrotized and has a strong vascular stalk. And the lesion that was on the above, of course, if you look at it really carefully and rotate, you're starting to get all these little extending branches, and it has a strong vascular stalk. But also it's a well circumscribed mass. So what about the pathology that is seen in this image? Well, what about the pathology in this, or this, or this, or even this? Every one of these images had a cancer or a benign lesion. So the purpose of this presentation, hopefully I'll give you some strategies to notice and work up the camouflaging lesion. It may be something that's been seen on mammogram or MRI. It may be a palpable lesion that the patient can feel, but it hasn't been seen on the other modalities. You may just pick it up in your general survey, and we're doing a lot of this now. So we're working together with the mammogram and the radiologist and the MRI person. And these are for both benign and malignant lesions. Lesions can camouflage because they may be isoechoic to the surrounding tissue, just like a fibroadenoma amongst fat. They may lie amongst the shadowing Cooper's ligaments. They may be within a dense breast, and you haven't used enough penetration. You must always penetrate to the chest wall. You might need more compression. Breast ultrasound must have a mixture of compression and non-compression. You may need less compression and low flow settings to see flow in the mass, or even with Toshiba, use SMI for these lovely low flow settings. The vessels within these masses are very compressible and very fragile. It may be larger than the probe size, so the anatomical variation may not have been recognised. It may not even have a mass. It may be an infiltrative invasive mass, and you don't have to find edges. Now, the patient position may be varied throughout the scan. Generally, we do position the patient rolled with the side scan being raised and the nipple forming the centre of the clock face with the ipsilateral arm raised, if possible. You need that breast flattened as evenly and thinly as possible, but do be prepared to optimise for the area being scanned. And this is particularly important when we're trying to look for a special lesion or a very, very large breast. If it's a medial side lesion, you may need that patient to even be supine or even roll them onto that side of interest. And the opposite for the lateral lesions, you may need to raise as far as decubitus. If they're a huge breast and they've got the breast extending under the chin, you may even need to partially or fully sit. And if it's an inferior lesion, the patient may be supine, or you may even require that patient with the pendulous breast to hold the breast up. I always scan from out to in, so it avoids the dragging of the tissue. So that degree of obliquity really does depend on that breast size, location of the lesion. You may even need to look in the mammo position if that's the only way you've seen that lesion, and then gradually hold your probe and lie them back down so that they can be prepared for other investigations such as biopsy. Even imaging the position the patient feels the lump. So yes, it's a systematic scan. I tend to survey in long and trans, quadrant by quadrant when I'm teaching. Some people do radial or anti-radial. And then we image around the clock face in all our clock positions. However, when we document, it must be consistent. And that's so that you can follow up. There's nothing more frustrating when it hasn't been documented properly. So we document the lesion's dimensions, the orientation that we're looking in, whether it's long trans or radial, anti-radial, the clock position, and measure with a ruler. And if there's more than 2 lesions and they're close, to assist with surgical options, you may even like to say how far apart they are. And of course, we describe the lesion's characteristics, such as their margins and echogenicity, shape, and what sort of enhancement or lobulations and vascularity. So it's no use just going and imaging in radial and anti-radial when, in this case, the person's breast cancer was 17 millimetres in trans, in radial. However, when we went trans, it was 22 millimetres. That brings it up into a total new area for staging. And this is really important for planning for the doctors. So be aware of your longest axis of the tumour, and then of course we measure 90 degrees to that. It is very important whether you've got a background in radiography or not to understand reading of mammograms. These triangulation sheets are fantastic, and this is really important when we're looking for really camouflaging lesions. Take the mammogram and the previous worksheets that have been done, the previous ultrasound, into the ultrasound room, and correlate with that mammogram. Compare with the previous ultrasounds and palpate that lesion. Just beware that on the MLO, medial lesion will appear lower, and on the MLO, lateral lesion will appear slightly higher. And that is really important. So basically, we're going to use multiple patient positions and probe angles and orientation. If it's a palpable lump, palpate it while you're scanning. You can even use a standoff to have a look to see what you're scanning, because it might help you differentiate if it's natural mass or normal fibriglandular tissue. And be prepared to change from default settings. I must admit, the current Toshiba modern settings with the Aplio Platinum series are fantastic, and I very rarely need to change from the settings that they have actually set up. But you have to be aware that you can use TSO, which is tissue specific optimization. It's like an automatic setting, or low flow settings such as SMI. And you may like to change your magnification, dynamic range, and even frequencies. So let us start with this first lesion. It's a follow-up on a known fibroadenoma. We know it's at 10 o'clock or about 6 o'clock because we've looked at previous films. So initially the sonographer on their previous setups, which were on the default settings were compound and smoothing, this is on an older unit, they couldn't see it until they added in their harmonics. And then they used multiple angles. So eventually they actually ended up going back to fundamental settings, and of course there was a location marker. This is actually a fibroadenoma. Now with location markers, particularly the sort that are like this, you will often have to be exactly perpendicular or closely perpendicular to actually see them correctly. So this means you need to change your probe angles. Here's another one. This is a 47-year-old for a routine screen, which the radiologist has seen a lesion which is about 10 o'clock in the breast. Initially the sonographer is looking for the lesion. She's actually ended up again having to put on harmonics and then making up that area she thinks it is, and using low flow settings of 2 to 5 cms per second, and then rotating. And as she's rotating, she's actually recognizing the spiculations and angular margins. And this was a breast cancer, which is quite isoechoic and looks like it's extending up into the hypodermal layer. The next one's a small lesion that was seen at 2 o'clock region on a mammogram, and the doctor has had to have the patient come back because initially the sonographer did not see the lesion. I've gone in to assist, and this is an older Toshiba that we used many years ago. And this is where it's really, really important to understand the anatomy of the breast. So breast ultrasound is a mixture of compression and light-handed scanning. I've gone through and recognised that we're actually missing a few ducts here, and then I've rolled the patient a little bit more because it's lateral, and then gone through with a little bit of a firmer hand. And when I've used compression, you can see that we've now got angular margins and a slightly spiculated lesion. We're even getting a bit of calcification. I'd love to see this on today's settings because I think you'd pick up that calcification much more. So always think about that anatomy as you're ultrasounding the breast. That tissue with every breast, as you know, varies with the breast type. It might be a fatty breast, it might be a fibrous breast, it might be a glandular breast. And this varies with the age, the obesity, and the hormonal status. But basically with the breast, we have 3 layers. We've got the dermal hypodermal layer, and then the breast parenchyma is housed between the pre-mammary fascia and the retromammary fascia. And you're actually going to find most of the breast pathology in this region. And then, of course, we're going to think about the ducts and the interlobular fat that's within this region. Then we've got the retromammary layer, where we tend not to have much pathology. However, you can get extension of pathology in this region. And we need to see the pectoral and right back to the pleura. We've even seen masses in the pleural spaces. So, of course, in this case, we looked for the normal anatomy to find the abnormal, and we're missing these ducts, and then we've gone through with compression. The terminal ductal lobular unit, which I talked about before, is that functional unit of the breast, and it's composed of a lobule and its terminal duct. And most of that breast pathology, such as ductal carcinoma in situ, lobular carcinomas and fibroadenomas, will start here. And apocrine, metaplasia and adenosis. And with the cancers, they'll migrate down and then across generally, unless they extend out and become wider than tall. But sometimes that terminal ductal lobular unit will come up into the Cooper's ligament, and that's what was happening with that previous lesion that looked like it was in the hypodermal layer. This is where you get the ski slope type pre-mammary fascia, and therefore generally in the hypodermal layer you think of things have been benign lesions, but this is when you can get confused and there can be cancers looking like they're extending out of the parenchyma. But use light compression when you're looking at a mass with colour. You can see in the first image we've compressed rather sharply, and at 3.5 cms per second we have got no colour flow. However, when we eased off, we can see there's vascularity, and this, of course, was a breast cancer. Next case is a triplet. Her identical twin sister had had breast cancer, and her mammogram was very, very dense and a whiteout on mammo. And she was concerned about this area, and she actually had come back for a review because she'd actually presented to someone for a biopsy 9 months before, and the sonographer and radiologists had refused because they had thought there was nothing to biopsy. I'm not happy that we're seeing the whole breast tissue, and we're certainly not seeing to the chest wall. So I've done a bit of compression. And again, this is an older unit, and I'm thinking that we've probably got a star-shaped lesion sitting here. So I've gone, and this is when Shishiba first brought out precision, and put on precision, and you can see in the end result that we've got this lesion sitting here, and we're getting the desmoplastic reaction. So it's really important to see to the chest wall, and it's really, really important to go through these areas and recognize the true anatomy, which was missing here. Next image is a breast that's the radiologist and sonographer's nightmare. Multiple breast cysts. Very, very dense breast. We're going through and seeing multiple breast cysts. As we're going through, we're noticing that we've got a bit of a desmoplastic reaction and loss of that pre-mammary fascia. But of course, we're always going to do our scan in radial and anti-radial or trans and long. And as we're going through, we've located this lesion. And again, this is where you've got to look beyond the cysts and look for these lesions in two planes. And again, use compression and rotate whilst you're looking at an area of interest. Next one's a routine mammogram. Not all cancers are hypoechoic. The radiologist wasn't fussed about these images initially, and the sonographer who looked at the images just thought, oh, look, I'll double check this area that's a little bit more dense. And what she's gone is sat on this area, and she's recognised that she really has a change of anatomy from the other normal anatomy. You may even like to lower your dynamic range here. And then once you've looked, you turn. And she's got an abnormal vascularity. It's an echogenic blast. We've lost our normal anatomy as we're coming through to here. It stops here and here. You can see just the fine edges. It's really not really well defined. And this was actually an invasive lobular carcinoma, which has columns of normal cells between tumour cells. Here's another echogenic breast cancer. Now, this was seen right on the back wall of the mammogram, and you can see that it's about 12 o'clock and at least 7 centimetres away. So the actual sonographer has targeted this area, and as they're going through in their radial fashion, you can see that the pre-mammary fascia has been eaten through. This is the pre-mammary fascia. We can see the actual desmoplastic reaction here, and we've got loss of normal anatomy all the way through here. So then he is actually turned and seeing that he's lost totally with a bit more compression the anatomy. So he's put on colour, and we've got this strong vascular stalk. So he's certainly found the area. And then, of course, the person has an abnormal lymph node. Here we have a 40-year-old woman for a routine mammogram. And this is when you work with the radiologist. They've had tomosynthesis, and the radiologist thought that there was something perhaps out here that they're interested in, and maybe even something further out. And they're quite large breasts, so it's a bit of a fishing trip for the sonographer. And he's really looked and measured off the mammograms and realised at 10 o'clock, 6 centimetres from the nipple, there's going to be something. And as he's gone through, he's realised he's got, again, this echogenic blush. He's used compression, and I must admit, once he's put colour power on, he's actually recognised the anatomical change. And yes, this was a ductal carcinoma in situ. But of course, he's got to go out and look further for the other lesion. And as he goes out further, he's seeing this area of shadowing. But it could just be the dense tissue that's overriding it. So he's gone from underneath, he's gone from another angle. And again, we can see that we're missing the tissue as we come through here. And this is another lesion, another ductal invasive carcinoma. But what about this one? You've got to take it into clinical context as well. This was a 50-year-old, and she had a tender left breast. She's got a dilated duct working up to the area that she's very tender in, and a little bit of a vascular ring and a little bit of a cystic change. So is this an abscess, or is this going to be a cancer, another cancer? So she's been treated before and after with 2 courses of antibiotics. And now they've come back for a review. And we can see here in anti-radial, we're trying to recognise the same tissue. We've got the Cooper's ligament coming down, and they've lined up in exactly the same spot. And of course, this area has resolved. And this was actually an area that was starting to abscess. And they always need review. This is a 50-year-old female whose right breast feels solid. If we look really closely at the mammograms, we can see that this is more areas on the right breast of fine calcifications. And this is where Micropure for Toshiba is really going to work beautifully. So, looking at the anatomy, the sonographer is trying to identify the normal tissue. Well, we've got normal tissue here, and then suddenly we've lost the tissue as we're coming in towards the middle of the breast. If we have a look here, we're losing bits of the Cooper's ligament. And as you're going through, and often you recognise this more when you're looking in real time, as you're coming through, you're seeing little fine microcalcifications here. And this is where Micropure will really pull out these calcifications. Little fine microcalcifications on all of these, and areas of necrosis. So we're thinking we've got a large invasive carcinoma. So the patient's gone from an MRI, and it's certainly come up on MRI. So these areas were not cysts, they're areas of necrotizing breast tissue. So we've got areas of normal breast tissue and areas of abnormal breast tissue. Micropure is a microcalcification detection technology, and is especially helpful in DCIS and ductal spread, and microcalcifications that you see with recurrence. Sometimes that's your only signal in recurrence near scars. And hopefully it will improve the accuracy of biopsy under guidance. It uses an advanced algorithms and filtering techniques to enhance and display calcifications on a blue background. And the Micropure technology is even improving in itself. So here we have an example of a ductal extension with someone who had an area of recurrence going along the duct. This previous patient had had a left mastectomy, and now they're seeing something definitely on the mammogram. And this is at about 8 o'clock on the right breast. And we're trying to define the normal anatomy. Again, the pre-mammary fascia has been eaten through, and there's something extending all the way through. So the sonographer's put on colour and recognise that there are areas of calcification, necrosis and vascularity. This is normal tissue for this patient sitting further out, rather fatty tissue. So the patients come back for a biopsy, and this sonographer next has worked it up even more by lowering the dynamic range and using tighter compression, and this is where you're actually seeing the true mass edges. And you know, it's almost isocoque with the surrounding tissue. And this ended up being a lymphocystic lymphoma, and they had abnormal lymph nodes as well. So if you'd seen those lymph nodes and hadn't recognised the abnormality, you really needed to come back. So large breast lesions, especially those that are bigger than the probe size and in large dense breasts, can camouflage. And that is when it is really, really important that you look for the normal anatomy. You may compare with similar tissue in the same breast or in the other breast. You might like to split the screen or even use wide view. So let's look at this old one, but a goodie on the right-hand side. This lady had a large mucinous carcinoma. And what we're seeing is disrupted fascia. We're seeing disrupted ducts. And as we come around, we can see more disrupted ducts and areas of necrosis. This poor particular girl, which we've used panorama view to see an overview of the actual anatomy, was a 39-year-old, and she'd been ultrasounded twice in the last few years for an area of her breast that she was concerned about. And what's actually happened is the person who's done the scans, or the people who've done the scans, haven't recognised the change in anatomy. So now we're seeing lots of microcalcifications, and we can see this infiltrative process that's going through her breast. And she's got abnormal vascularity as well, and now an abnormal lymph node. So now we've sent her off for a mammogram. And of course you can easily see all these calcifications and breast cancer spread, multiple lesions throughout her breast. So look at the big picture. This was a patient that came back, and these are the old images for a review fibroadenoma. And if we look, this is what they thought were two fibroadenomas. But if you look very carefully, you can see there's actually a capsule around this area. And this, of course, wasn't a fibroadenoma, it actually was a hamartoma. These are the images on a Toshiba machine, and we could mag this up even more. But what we can do is look at the surrounding tissue effects. We can use the second hand. Usually I'll have a cloth in my hand and I'll push up the breast and look from underneath. And this is a hamartoma. Now hamartomas are within glandular tissue. It's made of that breast tissue, but in an abnormal fashion. So breast tissue is fibrous, glandular, and fatty tissue. So a fibroadenolipoma. So we can see here we've actually got fatty, fibrous, and glandular tissue. And I've got a few. This is the very first hamartoma I ever saw, almost 20 years ago. And here we have some hamartomas that we've seen as time goes past. So you can see that we've got abnormal breast tissue. Well, it's composed of normal breast tissue in an abnormal fashion, fibrous, glandular, and fatty tissue. Now the fatty breast, this is where TSO is quite handy. This is tissue-specific optimisation. And it's very handy for this and also for the lymph nodes in the armpit. And with fatty breasts, you can often have tissues camouflaging because they're isocoic within it. They might be fibroadenomas or even breast cancers such as this one, which is within a fatty involuted breast, but it's got a few little calcifications here. This one here, we've got to look for the normal anatomy. We've got to work out whether we've got a area of shadowing because we're looking at normal anatomy, or whether we're actually cutting off the little ducts going through. So another fatty breast. She was an 80-year-old with a thickening in her outer breast. And you could easily run past because this tissue here looks very similar to the hypodermal layer. But of course we're missing the anatomy as we're going through. So we put on our colour at low flow settings and use compression and rotate, and we realise we've got a true mass going through here. And we're starting to get a bit of a desmoplastic reaction. With that smaller one, that was a large breast, and this person had had breast cancer on the other breast many years before. And as the sonographer's going through, and the radiologist really hasn't seen much on their mammograms, they're noticing an area of shadowing. So they've decided to approach it from multiple directions. And they've come from underneath, and they've still got a small mass. So this is only a 3 millimetre breast cancer. So we've used SMI to colour enhance, and there is a colour stalk heading towards this small cancer. And yes, it was a ductal carcinoma, a brand new cancer. This patient can feel a thickening at 1 o'clock in their breast. And again, we've got all these large calcifications, which may be a deterrent for the radiologist. It's 1 o'clock, 11 centimetres. The sonographer is seeing an area of shadowing. So is this a Cooper's ligament? So they've come from another approach, and as they come from another approach, they're appreciating a bit of desmoplastic reaction. And this ended up in biopsy being an invasive ductal carcinoma. This is another small lesion. They're worried about this tiny little thing well away from the actual nipple. So this is at the right breast, around 10 o'clock, and well out. And the sonographer again has found an area of shadowing. And then they've approached from multiple planes, and they can see it's actually taller than wide and going through all these levels, even with compression and multiple angle changes. That was an invasive ductal carcinoma. The dense fibriglandular breast is always hard for the radiologist and the sonographer, and I must admit tomosynthesis is helping a lot. But trouble is, we often go around the breast and we'll see multiple areas of shadowing from Cooper's ligaments, and that's where we need to come from underneath. So is this a true lesion? The sonographer's gone from underneath, and then they've rotated out, and this was actually just fatty breast tissue. You may like to heel toe, or you may like to rotate and come from under. But here we have another routine screen on a moderately dense breast. And this is where the sonographers can be very helpful. Nothing was seen initially by the radiologist, but she's come up with 2 areas of concern, one at 12 o'clock, 6 centimetres from the nipple, and one in the axillary tail. So she's then using 2-handed compression, and she's going to heel toe and look for breaks in fascial ducts on the one at 12 o'clock. And when she's worked this up, she could even mag this a lot more. She's seeing these little microcalcifications eventually. So she's had to get underneath this fibrous layer, and this was a ductal carcinoma. And then out at the axillary tail, she's again approached from multiple directions, and she again can see a mass-like area which she has called, mainly because of this area here, you can see that you're losing your anatomy. And this again ended up being a cancer. So always think the multifocal. Next one was a lady who had a palpable lesion at 6 o'clock, not far from her nipple. And initially, even though you can see a little bit there of density near the nipple, the radiologist was non-fussed. But on retrospect, he was convinced. Initially, I started using the 14 megahertz probe, and we can see that we've got a dilated duct, and that can lead you to things. So I've come down to here where she feels she's feeling something, and I'm not happy about this anatomy in this region. But of course, it's so superficial, I can use the 18 megahertz probe. So what I've gone is used the 18 megahertz probe. Initially, I was fine-tuning myself on this until I realized it was actually the anatomy up here. That was actually the true mass. And we're starting to break through the anatomy and looking at little tiny fine calcifications. So you can compare the 18 on this side and see that it's got much more detail than the same images on the 14. Okay, both of them are showing areas of vascularity, but it's much more enhanced on the 18. Is this a true lesion? This is the opposite case. You really need to penetrate to the chest wall. We're wondering if this is a granuloma or do we have a breast cancer? And in this particular case, we've actually had to go down to the 9 megahertz probe, and when we've gone to 9 megahertz, we can actually appreciate the desmoplastic reaction, and this was a large breast cancer. So sometimes to see the posterior wall, because with ultrasound, because we're lying supine, it may look like the cancer is actually biting through the pectoral muscle. But of course, they're going to resolve that on MRI or mammogram where they pull the breast tissue out. We've rolled this patient and it wasn't affecting the posterior wall. It was very close, but not going through the pectoral muscle. Sometimes you are asked to work out people with multiple fibroadenomas. Sometimes, you know, you've got 15, 20 fibroadenomas and you're wondering if you're looking at fat and making things up. Now, fat lobules compress more, and fat lobules have this line sign going through often. You may like to look from an angle, change of angle of approach and come from afar and turn and roll out. And in this case, what was being reviewed as a fibroadenoma was actually continuous fat. And while you're compressing, look at the surrounding tissue effects. Benign lesions will push away the fascial layers, and of course, malignant lesions like this, which may camouflage as a fibroadenoma, don't. Fibroadenomas may tilt. Malignant lesions will drag that surrounding tissue. You may use the ultrasound advantage of dynamics and test the compressibility. Elastography can be used, and use the probe to test the compressibility. Benign lesions are much more compressible, and in this situation, these were actually mobile particles within the cyst, so we're using ballottement, pushing up and down on it to see if it is mobile. So remember, benign lesions are smooth and well circumscribed, and they push out the fascial layers. They've got absence of any malignant findings. They may be ellipsoid in shape and usually parallel to the skin, may have 3 or fewer gentle lobulations, but I really think the most important thing, just like when you're looking at thyroid masses or anything, you're looking for a thin, complete echogenic capsule. Malignant lesions will have an irregular, thicker, incomplete capsule, and they'll disrupt the tissue planes. These ones won't. So is this a benign lesion, a cyst, or a cancer? Well, for a start, we need the fat set at a lower level of grey. This was too low. We needed to increase our shades of grey, and we can see that there's actually solid components and a little angular margins. And then we rotate on it, and we can see that this actually is a cancer. Is this a cyst or fibroadenoma at 10 o'clock in the left breast? The sonographer's having a look, and she's realised it's an abnormal looking cyst initially, but then she's starting to focus on these areas of cysts or necrosis. I must admit, I'm not happy with what's going on through here. So what should I do next? I should add colour and lay off my compression. When I add colour, I can see that there's a colour vascularity going through here, because this is where the cancer is now spreading through to the hyperdermal layer. So rather than being a couple, she's now worked it up, and this was a really good workup by a student. She's worked up that it's the whole area is a breast cancer. And this was a highly necrotizing breast cancer, and she had abnormal lymph nodes as well. However, not all cancers will look like a mass. Some are diffuse. This lady had had a previous breast cancer 9 years ago at 1 o'clock, and this is the region of scarring. She has a known fibroadenoma in the left breast at 3 o'clock. But the doctor, and this is where you must work with the radiologist, wasn't happy on the tomosynthesis of what was happening around 3 and 4. And I've put up some normal breast tissue from the same patient in the same breast, just so you can appreciate the normal tissue. You can see that you may go across this and if you're just looking at shades of grey, but if you're thinking about the anatomy, there are areas of fine calcifications. It'd be great to have Micropure here. We've got areas of necrosis. We're getting areas of normal breast and abnormal breast, and this was a highly invasive diffuse lesion infiltrating through this area, and really not that obvious on the actual mammogram. Inflammatory cancers are a rare form of breast cancer, and they can mimic mastitis. With this rapid onset of warmth and arrhythmia and breast enlargement, you might get this pot d'orange reddened area, and you might even have a palpable underlying mass. You may even get nipple retraction and crusting, and these sorts of people will often have neoadjuvant therapy, chemotherapy before surgery and radiotherapy. And sometimes you'll recognise this thickened skin and might be mistaking this as a mastitis, but they would always need review. This lady was 2 years post-breast cancer. This was away from the scar but near the scar, and the sonographer was going through, and they're seeing this area that's again gone through the pre-mammary fascia. And this was a new breast cancer. It wasn't a recurrence, not far from the scar. A new invasive cancer and abnormal lymph nodes. So optimise the setting so the fat is a medium grey and focus at that level being analysed. And if you undergain, it may look like a cyst, whereas you've got this large breast cancer. And always look for multiple pathologies. This is an oldie, and I've shown this a few times, but a goodie with this lady who has implants. She felt nothing. She'd previously had cysts and fibroadenomas on her ultrasounds before. So we've looked at the 12 o'clock lesion and think, oh, is this a hamartoma? And then we go around and look at the 2 o'clock area and we see what might be the cyst and a fibroadenoma, but there's an intramammary lymph node that looks a bit abnormal. I've gone around to 7 o'clock and we can see with the very little tissue that she's actually got this break through the normal breast tissue. So we've got to rotate on this and magnify and work up, and we can appreciate that this is actually a little breast cancer and starting to get little calcifications. So then we go around to 10 o'clock. Not much seen on the mammogram at this stage, but we can see these little calcifications and this multiple branching lesion. So that's nearly 3 centimetres in size, and we've sent it in 2 planes. So then we go out to 10 o'clock, and at 10 o'clock, at 3 centimetres from the nipple, there's what looks like another breast cancer, and then out in the axillary tail, yet another breast cancer. And then, of course, we go to the lymph nodes, and looking in the lymph nodes, we've got abnormal lymph nodes as well. So the next area for camouflaging lesion is really where you need to differentiate something that is camouflaging as something benign in the hypodermal fat layer. Because sometimes they can actually work up, malignancies can work up through, like we saw before, through the Cooper's ligament. A lesion is completely dermal if it's totally within that skin layer, the dermal and hypodermal layer. It may be dermal or hypodermal if there's a track leading to the skin, or there's this echogenic claw sign that we can see. So we know that this is sitting within that dermal layer, and this is just either an epidermoid or sebaceous cyst, unlike this one, which is lower and going through the actual pre-mammary fascia in a very thin patient. And you may like to use a standoff to scan these areas. So what about this one? Is this a dermal or hypodermal layer? Well, we can see this is the dermis, so this is actually, again, another epidermoid cyst sitting within the dermal layer in a thin patient. And there are a lot of things that can occur in the dermal layer and hypodermal layer. You can have oily cysts, or you can have ingrown hairs, you can have fat necrosis or lipomas. But you've got to take things in the clinical context, because this lady had previous melanomas, and not far away from one of her melanomas she had recent growths of lesions, and they look very much like fat necrosis, but these were actually breast metastases, melanoma metastases in the hypodermal layer. And of course, sometimes you will even find thrombosis in any of the sets of veins that drain the breast. But like any superficial thrombosis, you will be able to extend along that vein until it becomes patent, so you know it actually is a vein. And this Mondor's thrombophlebitis is often self-limiting. The other area that's the hardest area for camouflaging lesions is behind the nipple. And of course, with the nipple, if the room's not warm, it may be hard, and you'll get lots of shadowing. So you need a warm room and a light hand and no compression and lots of gel. But ultimately, we're trying to get perpendicular to that duct with our beam. So if we're going to have the actual ducts coming up this way, we're going to need to angle. And these are changes that happen with things that can happen under the nipple with a condition such as Paget's disease. Now, I think most of us will look under the nipple from multiple directions and try and heel toe. But I must admit, I've seen areas that look like breast cancers that I've worked out when I've actually had a look with a steep angle and aligned to that duct. Sometimes you'll use a second hand. I must admit I don't do it like this. I actually put a cloth and I use a fist and I push the nipple across, and it has helped me many times to find lesions deep to the nipple, and particularly papillomas. Stavros has talked about the rolled nipple technique, but again I think I'd be putting a cloth in my hand and push the actual nipple from the other way, and with the probe pushing on the tissue from the other side. And that's when you get more parallel to these ducts. And he finds they're the best for papillomas. You can work these areas up. It's nice if there's a bit of fluid in there, but sometimes, just like with shoulder ultrasound with the supraspinatus, by moving around that area of duct, you can actually put the fluid around the papilloma, which wasn't previously seen and was camouflaging. And this is a papilloma in the breast. Here we have a 25-year-old with a papilloma, which looks a bit like a fibroadenoma. Again, we can use our second hand to roll that area and work the fluid into the duct, and we realise it actually is within the duct. Ease off, and it was a proven papilloma. And look for second papillomas. Here we have a lady who was bleeding from a nipple, and you could easily see the papilloma directly under the nipple, but when you went out along the ducts, further along, and put on a colour area, you can see a colour stalk, and this was another camouflaging papilloma out near the edge of the areolar tissue. So use ballotment in these areas. You may have a DCIS, or it might be insipated secretions. Or you might even like to roll the patient, like with this person with the galactocele not far from the nipple, where we've got the fat fluid layer in the galactocele. This unfortunate case was a 19-year-old who'd had nipple discharge. And don't ignore these young patients when they come in, because she had a change of anatomy which wasn't originally recognised. And we can see multiple little fine calcifications. And when you think about it, they're actually calcifications going along the duct. So these are multiple little calcifications, and she had an invasive ductal carcinoma. So in conclusion, I understand the pressures sonographers are under, but think about the ultrasound anatomy while scanning and correlate that anatomy to the ultrasound and mammogram and MRI. Vary your probe technique and compression and your angle of approach. Use that second hand to check the surrounding tissue effects or give you another window. And understand your machine. Don't be afraid to change your settings to optimize. And do be prepared to optimize the breast position. Take time to look at the images and work up those areas of suspicion, and do think about multiple lesions. Just because you've found one cancer doesn't mean there's not another. And I'd like to thank those from the northeastern region of MIA for their assistance. Thank you. And that is the end of my talk. Any questions?
Thank you, Louise. We'll just see if anyone's got any questions out there. So if you can submit your questions through the chat feature. And we'll just give it a few moments for everyone to write down their questions. Can you put your references up again, please, Louise?
Absolutely.
Yeah, there's some. There is a question here. So if you have a mass with low-level echoes and you put harmonics on, which makes it anechoic, do you think it is a cyst?
It depends on the size and also the level of the gain. I think the gain is still really important. And looking at the margins as well, you know, you really want those lovely, clear, sharp, crystal-like margins. And yes, if that's the case, I would think it was a cyst. Because you tend to find, if they've got a sort of a solid component, I must admit, you can have insipated secretions inside a cyst or a cyst with hemorrhage. You can get some echoes in those as well. But cysts tend to have that crisp margins, you know, those sharp margins and good throughput.
Excellent. All right, this is the final call for questions. There was a question there.
Do I use elastography regularly? I don't have it available to me, so I can't say I do, Forka, but I know you've got it available to you. It would be lovely to have that extra tool. The other tool that I would adore to have now would be Micropure. Because I'm getting much better at picking up the little fine calcifications, particularly with areas of recurrence, and particularly with the new Toshiba setups. It's really great, and I notice our staff are the same. That's why we're picking up these tiny cancers now.
Yeah, I did see some really small cancers on your slides, yeah.
And they're really,
we have one more question.
People that
carry on, Louise.
Sorry, it seems to be the same people picking up these cancers, so they've really tuned into the anatomy, and you know, and looking at the X-rays before they do it. You know, not just listening totally to what the radiologist is saying.
Thank you. What cortical thickness for a lymph node do you use as abnormal?
Yes, now that's a whole new talk. It's what the lymph nodes look like more than. Generally, yes, greater than 3, but if they're eccentric, it's more the look of the lymph node, whether there's indentations, what the hilus looks like. Because you can have some people who have, generally most of their cortex is a little around the borderline 3 to 4 millimeters, and they're quite normal. And then you can have those who have got these very large round lymph nodes that have got fatty, and they're fatty hilars. So, you know, that's a total new talk, that one. But 3 is generally the rule of thumb, yes.
There is another question here. Do you think there is a future role for contrast ultrasound for breast?
At the moment, I'm not seeing it, but, you know, it's like anything that's new technologies. You know, if it's easy at hand, you know, the thing that stops us with a lot of contrast in private radiology is the cost. And so we really don't get time to work up these areas. So no, not at the moment. Yeah. Whether it will be
that would be an interesting space to watch. Yeah.
Lymph nodes look like and how, you know, it's spread. So, you know, where if you've got an area that it's thickened in one area, or and see the ones that I showed, they were mostly eccentric lymph nodes, and messy vascular branching. You'll have vascularity going to the actual periphery of the lymph node, not always but often. But yes, basically you can't be hard fast by saying just 3 millimeters. It's got to be done in the whole context of what you're imaging and seeing. One in the breast and all the other lymph nodes as well. You know, I've got, in my lymph node talk, you'll have some lymph nodes that are the same axilla that are abnormal and normal. So it's a whole area of discussion with and Stavros has covered that really well in his book.
And Louise, how much time do you allocate to your ultrasound?
We allow half an hour for all breast ultrasounds. Now, that's for bilateral breasts. However, we used to have a shortened time for single breasts, but now we realise that we're often, if they were booking for a single breast, we then ended up doing both anyway. So it's 30 minutes for all breast ultrasounds in our clinic. And, you know, sometimes when you've got a breast full of fibroadenomas and cysts, it might take you shorter to scan, but a long time to draw up. And, you know, then you sort of adjust that around what you're doing that day.
There is one final question here which says, you mentioned seeing abnormal lymph nodes, which didn't look particularly sinister. What criteria do you use to categorize lymph nodes as abnormal? We've kind of gone over this a little bit, but if you can just kind of give an overview.
I could put up a whole range of different looking lymph nodes. Yes, okay, we used to say, you know, looking at the axis and, you know, an oval shaped lymph node, but of course people can have rounded fatty lymph nodes. So yes, 3 millimeters for the cortex. But generally, if one area, if you look closely at the lymph node and you elongate to the lymph node axis, and one end is thicker than the other, and the other one's nice, thin and even, well, then you would probably be thinking that that might be abnormal. Then you're looking for messy vascular branching. You're looking at the hilum margins. Sometimes you end up with slit-like hilums. You can have no hilum. And of course, the vascularity is messy vascular branching, not from a vascular stalk coming through the hilum that you'd get with inflammatory lymph nodes. So, as I said, that's another talk which has been done a few times by people. You can even see with some lymph nodes with the vascular, the actual spread, you look at the capillary of that lymph node, and just like with cysts, a normal lymph node will have a nice clear margins. Abnormal ones will often have incomplete margins. Because the abnormal lymph doesn't come from in the hilar area, it comes from the outside, it comes from the cortex, through the afferent vessels of the cortex. So it logs on from the outside, the cancers.